define the concepts and principles of health assessment and health promotion in nursing. Then we also need to identify the techniques of a comprehensive health history and physical examination of a patient. Then we have to apply the nursing process and clinical reasoning to collect, analyze, and interpret data from various sources of health information. So when you collect your data, you need to analyze, you interpret, so that you can be able to come up with the right information on how you are going to diagnose and manage your patient. And the fourth objective is to demonstrate effective communication and interpersonal skills in establishing rapport and conducting health assessments with diverse kind of clients across the lifespan. So those are basically the objectives that we need to cover up today. And I believe we shall be able to get done within either 1.5 hours. Um, we need to start with a definition. And I believe most of us have been doing health assessment on our patients. I think I'm not dealing with people who have never seen a patient or who have never worked on a patient. Is there someone among us who has never interacted with a patient? Hello?
Yes, Gladys. I think for my side, I've been going through all the history taking, health assessment of the patients.
Yes.
So I
So
have
there is
some
nothing.
experience. Yeah.
Thank you so much. So there is nothing so much different. It is basically what we have been doing, but how do we do it? So health assessment is just a process of collecting, analyzing, and interpreting data about a client's health status, the needs of the client, our preferences, and the risks. So it involves the use of evidence-based knowledge, skills, and strategies to provide holistic and client-centered and cultural kind of sensitive care. So when you collect this data, you should be able to have that evidence-based kind of knowledge. Whatever you do, there should be evidence. Nowadays, we don't do things for fun, but you have to do something that you have evidence about it and you're able to defend it. So we should also be having skills on how we assess our patients. We should also be client-centered. Client-centered is basically looking at a patient as an individual, not as a group. Because when patients come to you, they come with different issues, they come with different problems. So you should not put them as a group, but you handle a patient as an individual, and that is what they mean by client-centered kind of management or assessment. Then cultural sensitive care. This one we have to look at the cultures of different patients that we interact with. Patients come, but they have their different cultures. They have their own different kind of beliefs. So when you're handling them, you have to put that into consideration so that you don't actually offend them during the time of your assessment. What is the purpose? There should be a purpose on why you are doing your health assessment. So the first thing you need to look at is screening for general kind of well-being. How is the patient? And this one can be involving triaging of these patients. So when you're screening the patients, generally you have to look at how they are presented themselves to you. There are those ones who are very sick. So when they come, you have to sort them out and intervene immediately. Then there are those ones who can wait. So you have to screen them according to their general well-being as they present to you. Then validation of the complaints. As they give you their complaints, you have to validate to see whether the complaint that the patient is giving you is actually of a good evidence, or you can use that information to guide you in the management of this patient. Because when they present you with their complaints, not every complaint a patient gives you can be of value. So you have to validate and see how important the complaint of the patient can be in the management of these patients. And monitoring current health problems of the patient is very important. Formulation of diagnosis and treatment is also very important, because if you don't get a proper diagnosis, then you're going to mismanage your patient in the treatment. So the diagnosis is very, very key, and this one you can get it very well when you do a proper health assessment. Then you can also be able to give the right treatment. Then development of the nursing care plan. We need to have a good nursing care plan, and this one you have to prioritize depending on the diagnosis that you have got for the patient. Then you have to prioritize which one is life threatening, and you start managing the patient accordingly. So practical considerations when you now dealing with this patient, what do you have to consider practically? So there are some techniques that may require clothing removal or position changes. So when you invite the patient to the room where you're going to examine this patient, you should be able to look at what you're going to do to this patient exactly, so that you can provide privacy, because it's not good for you to open this patient amidst other patients. So there are some other sides of the body, either on the chest, the abdomen, the pelvic region, that may need removing the clothes so that you can view and see very well where the patient is telling you is feeling either pain and so forth. So it needs a technique on how you're going to do it. And sometimes where there is involving removing clothes, even the opposite sex, there should be some that you address someone to remove his clothes or to remove her clothes, because many times they have always alleged so many things during the time of examining the patients, when the doctor or the nurse is alone with the patient, so many things happen. So we also need to ensure privacy. When you ensure privacy and then safety, and then also we need to have a quiet environment. And in a quiet environment, we need to have good lighting. So when there is good lighting, it can help us to see very well what is happening on this patient. We can be able to see very well what is either on the skin of this patient, so that we can be able to address the complaints of these patients. So on assessment, we need to have privacy, because we may end up removing this patient's clothes. We need to see that this patient is safe, and also the environment is quiet so that the patient is able to express himself, and also good lighting so that we can be able to view very well on what is happening on the patient. And then the tools. During the time of assessment, we need tools to use. And Tito, you said you've been interacting with these patients, and I believe you've been assessing them. I don't know whether you can give us some of the tools that you have been using during the process of patient assessment or health assessment. Can you give us some of them that you've been using? Yes, Tito.
Yes, please. I can give some examples.
Yes.
Uh, One of them is a stethoscope, the one we use to examine the chest and the abdomen. We can also have some like a thermometer for measuring the temperature.
Yes.
We, we can also have the BP machine for measuring the blood pressure, and we
Yes.
also can have the for physical examination like patella, hammer, because you will go and
Uh-huh.
conduct the physical examination. We also
Yes.
have even the ostoscope, the one for examining the
Yes.
ear. And there are
Okay.
many,
Thank you
I
very
can
much.
give them many.
Yeah, there are very many depending on what you're going to assess from the patient. So basically, we are going to use these tools that you've mentioned, and as you're using these tools, some of them can be tools that we are going to insert on different areas of the patient or different sides of the patient, and they must be disinfected. Some of them have to be sterilized and ready depending on the procedure that you're going to do on the patient. Most of the instruments or the equipments that we use to insert on the patients, maybe when you're going to do a pelvic examination, vaginal examinations, you're going to use a spatula, or you're going to use either a sponge holding forceps, that is mostly in obstetric and gyne. So those equipments or those tools must be disinfected or must be sterilized before you insert them to the patient. But also the stethoscope, when you use it on one patient, you should make sure that you disinfect it before you put it on the other patient, because you can cross-infect infection from one patient to another. So we have to maintain sterility so that we prevent infecting our patients. Then also comfortable body position for the examiner and client is also crucial. So you have to make sure that your patient is comfortably either laying on the examination couch or sitting upright. Then you also, the examiner, you should be in a good position to be able to examine your client. Because if the client is not comfortable and you, the examiner, is not also comfortable, then you may not be able to actually examine this patient and come up with the right maybe outcome of what you've seen from this patient, and can mislead you in the diagnosis of this patient and possibly also on the management. So awareness of personal culture's impact on the therapeutic relationship. So this point is basically looking at, I talked about cultures. People have different cultures, they have their own different beliefs. So when you're managing them, you have also to be aware that this kind of tribe or this kind of religion, they believe they don't use this kind of maybe drugs. Some religions don't want to be transfused, so they can refuse. Even if they are anemic, they can refuse. So you have to be aware about people's cultures so that you can be able to actually convince them or help them understand the impact, the positive impact on the interventions that you're going to give them, so that they can easily accept your treatment or your medications. Then also you have to consider, there should be consideration of perceived examination quality based on ethnicity. So even the ethnic groups have different beliefs, they have different perceptions. So you have to look at someone according to his ethnicity, and you have to take them the way they are, so that you can be able to actually do the right thing and get the quality results as expected, so that you can be able to serve them or provide the services adequately. So when you look at this slide, it's telling us about the aspects of physical examination. So we want to look at what are these aspects when you're doing physical examination in relation to health assessment. So one of them is instrumentation, is the physical assessment. In physical assessment, like thermometer, and you mentioned them, Tito. I believe you listed most of these instruments, the ones that we use. We need a thermometer, we need a stethoscope, we need a BP machine, and etc. Then client considerations, we have to consider the age of the client, you have to consider the privacy of the client and the comfort of the client, so that we can be able to do the best of the physical assessment. So the examiner professionalism, you should also exercise professionalism. We have ethics, we have our professional code of conduct. So when we are handling these patients, we should handle them professionally, not handling them the way we feel, but we should use our professional aspect bit of it, so that these patients can respect us and these patients can actually trust us when we become professional in everything we do to them. And then also practice standard precautions. I believe we have different standards of providing different procedures. Those are standards of procedures in different aspects. So we need also to look at that. When we don't use the standard precautions, then we are going to get wrong findings. So we have to consider standard precautions or standard procedures on how we carry out our assessment, so that we can get the right results, and to help us get the right diagnosis and also lead us to the right management. Then general sequence of assessment techniques. So sequence is which one comes first, which one follows, and then which one ends. So those techniques, we need to know them. That when you finish to inspect, what do you do next? And then after maybe palpation, what do we do next? So we have to follow that sequence in a right way, so that we can be able to actually do the right thing for our clients and come up with the right assessment. Then patient education and cooperation. We also need to educate these patients when we assess them and we find maybe they have some issues, then we have to educate them. Or before when we start the assessment, we need to educate them and tell them the importance on why we are doing it so that they can comply with whatever we are telling them, and we shall be able to cooperate together with our patients and do the right assessment and come up with the right diagnosis. All this we are doing in assessment is basically to help us actually collect enough data that will help us generate the proper diagnosis and also come up with the right management of our patients. So we want to look at the components. What are the components of health assessment? So the components of health assessment, one is physical examination. So physical examination involves inspecting, palpating, percussing, and auscultating. And Tito, thank you very much for having listed all those tools. And those tools lead us to these different processes or sequences of assessing the patient. So you first inspect. After inspecting, then you can go into palpate, and after palpating, you can go to percuss and then auscultate. Those are the various body systems to identify normal and abnormal findings. So what we need to know here, we are supposed to know the normal, when you percuss, what is the normal sound that you hear, so that when you hear any sound that is not that one that you know is normal, then you know this is an abnormal sound, and then this can be maybe a different issue, or there is a problem with that particular area where you have percussed, and can help even to lead to another kind of assessment or even investigation to confirm what could be happening with your patient. Then comprehensive health history, we need to take different histories, and when we take these different histories, it will help us to come up with some comprehensive kind of idea and knowledge about what could be happening with our clients. So comprehensive health history is just assessment that provide valuable information about a client's current and past health problems, the lifestyle, family and social history, medications, allergies, and immunizations. So all these histories, you're supposed to take them so that you can be able to handle your patient wholesomely in every aspect of his life, and you'll be able to actually come up with the right diagnosis. Then the other thing is documentation. You have to document. When you've examined either the lymphatic system, what have you found? You document. So whatever you do to your patient, you have to document as evidence of your assessment, and that will lead you to your management. Then we want to look at legal issues. There are some other legal issues during health assessment, which we need also to understand that when we have these patients, there are also certain things that we need to look at in the legal aspect bit of it. So vigilance in conducting health assessments. So you have to be very vigilant, and that's why they say a nurse has to be observant, not just to do things the way you want, but you have to be having a rationale. You have to be knowing why you are doing certain things, and when you do that, it can help us even in the legal issues, because you're being so vigilant in your assessment, you're being able to do things the right way, and you can be able to support us in legal issues. So it is very important that when you're doing examinations or when you're doing health assessment, you have to be very vigilant. Then building trust with patients. We also have to build a trust with our patients. So when you build a trust with your patient, they will not doubt you. But if the patients do not trust you, they can doubt you, and anything slight, they can lead you to maybe even to be mistaken, to be doing something wrong. And that's why we realize some of our health workers, our colleagues, have been alleged of rape and so forth. So you have to first build the trust from these patients, and they also have to build the trust in you, so that even if you tell them, I want to examine you, remove your clothes, they are able to do it because they have trusted you. And the other thing is addressing patient protests and needs. Some patients can protest, they can refuse. If you tell them remove your clothes, they'll say, why are you telling me to remove my clothes? And for that reason, they can end up even questioning your patient and them in a polite way and let them understand why you are going to do it. And if they don't accept, don't force them. Then also you have to address their needs. Some of them may tell you, if it is a male doctor, I cannot be examined by a male doctor. If it is a female doctor, I can't be examined by a female doctor. And if they say so, address the need of that patient so that they can have trust in you and they'll be able to open up and give all the right information to the patient. I mean to you, the doctor or the nurse. Then proper documentation of procedures and injuries. So when you're doing this health assessment, you have also to document all the procedures you have done and any injuries that have occurred so that it can help you in any legal issues that can easily occur. Our patients are our friends, yes, but when a problem occurs, sometimes they can change. So it's very important for you to document as evidence so that you can be able to support yourself at any time when anything changes. So I don't know whether there is any question so far where we have reached. I would like to hear from you. Hello.
Yes, for me, it's clear. I'm getting it.
So Tito, you're with me in class. I'm only hearing your voice.
I'm seeing somebody called Gabriel. That part.
Gabriel, yes. So
I think
Gabriel, are you with us?
we're only two in the class.
Okay. But where you need any explanation, you pardon me and I will be able to take you back.
Okay.
We can move to the next slide, and that is our considerations in taking history. What do we need to consider as we are taking history as one of the things we are looking at in our health assessment? So one of it is communication skills. You have to have good skills of communication to our patients so that we can have a successful interview with our patients and they will be able to open to us. But if you have poor communication skills, sometimes the patients may also fail to open to us. Then physical setting. Physical setting can be the environment where you're going to sit with this patient. The room where you're going to be with this patient should also be of a good kind of state. Because if the environment alone is not conducive, it's not set well, the patient may decide not to speak to you. So we need privacy. The place has to be quiet and the room has to be comfortable, free from distractions, and you have to sit face to face with your patient and focus and be able to get the right information because we have non-verbal communication. It can be facial kind of impression, and if you're not sitting well or facing your patient, you may not be able to identify that this patient is expressing this and you may not be able to address such. Then professional behavior, I mentioned about professionalism. We have to express or to show our professional ethics so that we can be able to handle these patients. So the way we behave to them should be professional. Sometimes people tend to take it casual and yet the patient has built trust in you. So when you don't show that professional behavior, the patient can lose trust and you miss the information. And then patient-related variables. So if the patient is distressed, use a focused interview. Focused interview is basically looking at a specific thing. So if your patient is not able to tell you everything, but he has mentioned something, try to focus on that because that could be the only issue that has brought him. So if you go to other things, you may distract even that small information that you have got from this patient. So if the patient has different things that are distracting his mind, then just have a focused interview to pick something from that patient that can help direct you in his management. The art of asking questions, types of interview questions. So we need also to have different types of questions that we ask our patients. And then open-ended question. This one encourages a free flow and open response. So open-ended, the patient will just speak anything, and it is up to you, the health worker, to pick what you need to help this patient. So for them, they will just speak. You ask a question which is very open for a patient to express whatever is able to express to you. Then closed-ended, that one when you need a specific thing, so it requires 1 or 2 words or answers for a precise kind of detailed information. So you ask the patient a closed-ended question which directs him to the right answer immediately. Then directive. Directive leads patients on one set of thoughts. So it's only one thought and that is it. So it's like related to closed-ended, but it's a little bit different from closed-ended question. So directive is you are the one leading the patient to that answer, and the patient will be able to tell you exactly what you need to hear from him. But closed-ended, you're not directing the patient to say exactly what you need, but the patient will be able to respond with very few words. Not like the open-ended where the patient speaks too many things, but it's you now to know exactly what you need to pick out of what the patient has explained. So I want us to see the techniques that enhance data collection. So there are different techniques that can help us. Enhancing is basically just helping us or support us in data collection. So we have to look at active listening. We should not speak too much, but we should always be ready to listen. So the patient will be speaking, but you are the health worker. You should be able to listen and give time to this patient to speak. So you should avoid assumptions. Do not assume what the patient is saying. You should listen and assume what the patient is saying, but you should listen to this patient very well and then allow them. Then facilitation. You should use phrases. Facilitation is just like helping the patient, leading the patient onto speaking more. So you have to use like phrases to encourage patients to continue talking, and that is what we say facilitation. So active listening, facilitation is very important. So in facilitation, you can use words like, okay, I understand, go on, then, and so forth, and the patient continues, or you can use non-verbal cues like you nod your head, and the patient understands that you still need to hear more and more. And then the other thing is clarification. Clarification, this one, it is used to obtain information about conflicting or vague or ambiguous kind of statements. If you've not understood very well what the patient is saying, you can also try to seek for clarification so that you can be able to understand what the patient is saying. Maybe he has told you a statement and you don't understand. Then you say, what did you say? Do you mean this? Then the patient will clarify. Then restatement. Restatement is repeating what the patient has said, repeating what the patient has said for confirmation. So you repeat what the patient has mentioned, then the patient will tell you, yes, that's what I mean. Or the patient say, no, I meant this. So you restatement, you make a restatement for the patient to confirm what the patient wanted to tell you. Then reflection, and then confrontation and interpretation. So all that are techniques that can help us collect enough data that can lead us to proper diagnosis and management of our patients. Then managing awkward moments. There are some times whereby you get a patient and the patient is not responding. You get a patient and the patient is not even telling you exactly what has brought him, and you're there, but you're supposed to handle that patient. So how are you going to do this? Answering personal questions with a brief response. So you can be there talking to a patient, but the patient may refuse to talk. Then also silence for reflection or gathering courage. You can get a patient and you get even scared on how you're going to handle this patient. You get even scared on how you're going to approach this patient. So how are you going to do it? That is an awkward kind of moment that you can go through with patients. So how are you going to do it? You can just have a moment of silence and then you reflect and gather courage on how you're going to approach this patient. So when you feel like you cannot approach the patient at that time, don't force yourself, but try to compose yourself and see how am I going to talk to this patient. And this happens mostly in counseling or breaking bad news to the patients. You realize that it's hard to talk to this patient. How am I going to approach him? How am I going to approach them? But you have to gather courage and see how to talk to these patients. Then the other one is dealing with a crying patient. How are you going to deal with a patient who is crying? Maybe he has lost a relative, he has lost a child, and those are awkward moments in management or in assessing our patients. So you can just give support. And when a patient is crying, sometimes you cannot tell them to stop because it's something which is normal. When someone is hurt, the person will always have to cry. So you just give support to them and also just allow them bring out the anger, and there they can get relieved. Then addressing an angry patient directly to identify the source of anger. So when a patient is angry, don't actually run away from the patient, but try to find out from the patient, what is the problem? Why are you not happy? And the patient will tell you, I'm not happy because I came here, I've stayed for 4 hours, nobody has seen me. Then you realize actually this patient is not angry for nothing, but this patient has spent a lot of time not being attended to, and you may be able to help this patient. Then overly talkative patients may waste time for you to see other patients, or it may mislead you. So you have to use close-ended questions if you realize those kind of patients, and so forth. Below are other points. So what are the types of history? Tito, can you give us some of the histories that you always take from these patients when you're doing health assessment?
Uh, the first one is a history of presenting complaint. Uh, the second one is family history. The third one is the first medical history.
Mm,
We have also the surgical history of the patient,
mm,
and we have the childhood history, where you ask the whether the person when she was a child, either he has ever have some illnesses.
mm,
So, and also you start from biodata of the patient, which is
mm.
the name, the age, the sex, and all this, and then you go to all the histories taken. Yeah,
Okay.
that's what I can say.
So, thank you very much. So, when you're doing health history and you're collecting this assessment, we have different classifications of health history. So, we have to take the comprehensive history, and comprehensive history looks at what you have actually explained. Then you have to look at problem focused assessment. That one you are looking at basically the problem of the patient, what has brought the patient. But in comprehensive history, you're going to look at family history, social history, obstetric history, and all that. Then problem focused assessment, you're going to look at basically the problem of the patient, what has brought this patient. Then episodic. Episodic is just like information about recent or past events and experiences. Episode is an occurrence of an event. So when something happened maybe some years back, you're going to focus on that to ask the patient, so what happened? You said at that time you operated, what caused it, and where we operated from and all that. So you are looking at what happened at that time. So comprehensive history, assessment, it's basically assessment that is thorough and detailed evaluation of an individual's overall health and well-being. So you look at all that information comprehensively. So it involves gathering information about the person's medical history, lifestyle, family history, support, and social support, and any other are relevant factors that could have contributed to the illness. So comprehensive assessment looks at collecting all that information through all those histories, and you're able to come up with one kind of condition or problem that this patient is suffering from. So the goal is to create a holistic picture of the individual's health, taking into account the physical, psychological, and social aspect of your patient. Then problem focused I hinted on it. So it is basically more targeted and specific. So you're focusing on a particular health issue or concern of your patient, and it is often conducted when there is a specific problem or symptom that needs to be addressed at that time. So episodic assessment identify the problem, aiming to understand its cause, severity, and treatment options. So emergency situations or when addressing some other acute kind of conditions or problems. So that is what is problem focused assessment. It is looking at a specific problem of the patient. Episodic assessment, as I mentioned, it involves evaluating an individual's health during a specific episode or occurrence, and it may be conducted in response to a particular health event, such as an illness, as I mentioned, that it can be an injury or it can be any chronic condition that occurred some time back or which is occurring today. Then you only look at that. Then the focuses on the current episode, and it necessarily cover the individual's overall health status. You may not look at everything, but you are looking at that particular thing which has happened at that time. So episodic assessments are often conducted to manage and treat acute health problems. So you generally look at surgical conditions, the injuries. When a patient has come with a fracture, you are not going to ask a patient again histories of obstetric history, past medical history. You're just going to focus. The patient has got a fracture. What happened? What kind of a fracture? How are we going to fix this fracture? And that is it. So the types of health history, comprehensive, problem focused, episodic, and then the components of health history, which we consider the family history through a genogram. Genogram, I think we all understand. Genogram is more of genes. Family, it runs in families. So the genetic kind of conditions run in families, and when we ask them about family history, we are looking at those conditions which are genetically transformed to one generation to another and so forth, like sickle cells, sometimes diabetes, hypertension, people get them, whereby the mother can be having the grandmother, then now the children and so forth. So when a person comes with such kind of conditions, you're going to ask, is there someone in the family who had this? Then they will tell you, yeah, our grandmother had it, or else my father, my mother, my aunties, and then you know that this is a genogram kind of condition, looking at the family history. So I want us to look at cultural assessment. In cultural assessment, what do we focus on? You do not have to assume all people from a particular culture are the same. So you can say this person is from this part of the country, and those people are this kind of people, they believe in this. And that's why we said when we are managing this patient or when we are doing health assessment, we should be client-centered, looking at an individual as an individual, not generalizing. So in cultural assessment, you should look at a person who has come to you as an individual, don't generalize them. And when you generalize, you may end up actually offending this patient because maybe for him is not part of the other culture that you think. So you should not assume all people from a particular place or particular tribe are of the same kind of either behavior or some kind of beliefs. They might be different. So you should handle them in a client-centered manner. Then cultural encounters provide opportunities for nurses to interact with patients from culturally diverse backgrounds. So when you look at cultural behaviors or cultural aspect of it, culture is diverse. So in an organization or when you're a health worker handling a patient, you should be able to handle patients in relation to their cultural diversities so that you can be able to meet their needs and address their problems. So you don't put people as one. So learning about diverse cultural practices and beliefs. So you should know the different cultural beliefs and their practices so that you can not fix them into a certain corner and say these people from this area, this is how they behave. When you give them this, they take it in this manner. People of that religion, they don't accept blood transfusion. So if this one is anemic, let's not transfuse. No, an individual is an individual. A patient is a patient as an individual, not as a group. So some of them may get offended, or you may also make this patient miss the right management because you have generalized them according to the cultures. Then consider areas where touch may be forbidden or specific garments should not be removed. So you should also look at this as something very important. Then humility, acknowledgement of perceived power imbalances. You should also look at that because humility, people think humility is maybe being too humble and being so obedient. No, humility is basically you doing the right thing in a right way and the way you present yourself in a respectful manner to whoever you are attending to or whoever you are providing the service. Then consideration of power, privilege, and respect for culture during examination. So you should look at all this. When you're managing someone, don't say because I'm a doctor, so I have all the powers to tell you remove your clothes. No, you should have respect for these people and consider their cultures. If they say for me, I'm not removing my clothes, don't force them. If they say for me, I'm not being examined by a woman, let a man come and examine me as a fellow man. Respect their beliefs and their cultures. So humility is very important when we are providing services to these clients. Let's not show our powers because we are health workers. No, we have to understand our patients. So what are the types of physical assessment techniques? We have inspection. What do you do? What do you see or smell when you're inspecting? Then auscultation. What do you hear? Percussion, what do you hear? And also palpation, what do you feel? So when you're palpating, you're using your hands. When you're percussing, you're also using your hands. And then your ears have to hear. Then auscultation, you're basically going to hear what you're auscultating, and that is with the stethoscope. Then inspection, you will see, and then you're able to judge with your eyes on what you've seen. And you can also smell. When you're inspecting, you can feel some smell and you can be able to judge whether there is signs of infection, sepsis, is it what kind of bad smell and so forth. So physical assessment techniques are basically these four, that is inspection, auscultation, percussion, and palpation, and they go in that sequence. So sequence of assessment techniques, exactly that's what I've already mentioned in the previous slide. And then abdominal assessment sequence, you have to inspect. Then after inspecting, you auscultate, you percuss and palpate, which is the same. And that is the correct order when you're doing assessment technique. Then the palpation deferred to more experienced examiners for safety. So when you're doing deep palpation, it should not be so deep that you compress the organs, you compress the internal organs, and then you cause more damage. No. So when they say deep palpation, there's a way that you're going to do it gently to identify either the enlargement of the different organs, and you can be able to assess the size, the normal size, and any deviation in these organs. So on the inspection techniques, the purpose, you have to discover visual abnormalities, and you'll be able to see either bruising or wounds or scars, any kind of thing that you see abnormal on the skin. Then you'll be able to tell maybe this is due to either trauma or what. So it is best done in well lit areas to visualize color and textures. So the place should be more of light. There should be enough light so that you can be able to see how your patient's skin is, either from the abdomen, the back, whichever part. Then inspection is also a first technique in the physical exam. You first start by inspecting. So it is the first technique. Compare the two sides of the body for similarities and differences. So when you look at the patient, you have to compare. On this side, there are two breasts. Is the same, this breast the same like the other one? When you look at the abdomen, this side of the abdomen, is it enlarged or the abdomen is the same? This side and this side is the same, or one side is more enlarged. And you should be able to know which organs are on the different sides of the abdomen, and there you can suspect that maybe there is enlargement of a specific organ in a specific side of the abdomen, depending on either the enlargement, and when you go to palpate, you may realize actually there is an enlargement on that side due to enlarged organs. So on palpation techniques, you have it follows inspection for all body systems except the abdomen. So here it gathers more information on cues noticed during inspection. So when you inspect, then you go ahead to palpate. As I mentioned, you'll be able to get more information when you palpate to confirm what you saw on the inspection. So it also provides information on the texture, temperature, moisture, organ size and location, swelling, pulsation, firmness, and so forth. So when you palpate, you can be able to know that this patient is either having hypothermia or hyperthermia, either the skin is rough, the skin is moist because maybe the patient is getting into shock, the organ is either enlarged or you're not even locating the organ, and all that. So palpation gives you to confirm what you had seen during the time of inspection. Then use fingertips for fine differences in texture, swelling, pulsation, and the lumps. So when you're palpating, you don't use the tips of your fingers, but you're going to use the palms of your fingers so that you can be able to identify exactly the problem with the area that you might have sensed that there is a problem. So pinching motion for mass or small organ exploration. So you can be able to also try to confirm whether what you're touching or what you're palpating is actually what you're feeling. So when you're palpating the head, I want to give an example of a pregnant mother. When you're palpating and you realize that the head is either on the side or it is up, there's a way you put your fingers and you're trying to hold it firmly to confirm whether it is the head or it is the buttocks. So sometimes you go ahead to confirm during palpation whether what you're palpating is actually what you saw in the inspection, so that you can be able to confirm and accept that yes, maybe the liver is really enlarged or the spleen is enlarged. So the back of the hand assesses temperature. So the back of your hand, not the palms, but the back of your hand is the one that you put on top of the patient skin so that you can be able to feel the temperature of your patient. So you don't use your palms, but you turn on the back where there is the skin, not the palm. Behind your hands is where you use for feeling for the temperature. Then vibrations felt with the base of fingers or ulnar surfaces, and then examiner's hands as tools. We are requiring short fingernails and warmth. So when you examine the patient, your fingernails should be short because you might end up scratching the patient with your long nails. So you make sure that your fingernails are short. As a health worker, we are supposed to maintain our fingernails short. And before you touch the patient, you have to warm your hands, because if your hands are cold, you may scare the patient and you fail to get what you really need to find out from your patient. And touching with different parts of the hands are varying pressure. So you should, if you're touching the patient, touch the patient in a calm way, Just if you're feeling for the temperature, feel it with the back of your hand, and that is it. When you change to touch with your palms, then you may not get the right findings. You may say the patient is hot, then again you say as if he's not. So if they say that you're using the back of your hands for feeling for temperature of the patient, whether is it hot or is not, then you use it, but not changing your hands. Then keep fingernails short and hands warm. Palpate tender areas last, so that you don't interfere with the patient, because if you use if you palpate it deeper and the patient feels pain, the patient may not accept you to move to the other part. So where the patient tells you he feels pain, you should palpate there last, so that even if the patient shakes and refuses you to continue, then you had already finished the other parts. It will help you write up your information and document what you have found. Then gloves if contact with mucous membranes or body fluids is expected. So getting in contact with the patient's fluids is not good. If you know that you're going to examine this patient and you can easily get in contact with the fluids of this patient, please put on your gloves and examine the patient, because every fluid out of the patient is not safe for us. Then light palpation. I remember I said we should start with light palpation. Don't go direct to deep palpation. When you start with light palpation on the surface, it can give you a picture how the patient is feeling before you start the deep palpation. So the technique for surface abnormalities. So you're trying to look for any surface abnormalities. That's why we do the light palpation. Then depress skin a half to 3/4 inch with finger pads. So you use the finger pads, but you don't use your tips. When you use your tips, it looks like you're just pressing the patient. So you use your finger pads, but on the surface gently, and can help you to identify any abnormalities on the surface of the body or on the abdomen. So assess for texture. When you touch this patient, you can also be able to assess the texture. When you're doing palpation, you can be able to identify tenderness on those different areas. You can be able to assess for temperature at the same time. If the patient is hot, you can identify. If the patient is moist, you can also tell that this patient is moist. And then elasticity of the skin, and that one we are able to rule out either dehydration. When the skin is too much elastic, you pull the skin and it goes back very slowly. That means the patient is dehydrated. So you can also do that during that time. Then pulsations. Pulsations is basically looking at the blood vessels. And you realize that when you touch the blood vessels and you see the one that is pulsating very fast, you feel it, then that is an artery. So when you're trying to put a cannula, never put a cannula on the artery. Don't put the cannula in the arterial veins, because they will end up giving a backflow because of the force that is exerted on them. So when you touch, there's a lot of pulsation on them. So do not insert a cannula. If there's no pulsation, then you know that is the vein. And also on palpation, you can be able to assess any masses. Like breast examination, you can see there is a mass on this breast, and they can suspect either a cancer. So on deep palpation, the technique for internal organs and masses. So for superficial, you are looking at the superficial abnormalities, but for deep, you're looking at the internal organs and the masses. So you depress the skin 1.5 to 2 inches with the firm and deep pressure. So you go more deeper. After doing the superficial and you don't see your patient are feeling pain, there's no tenderness, then you can go further to press more deeper to see whether the inside organs are enlarged. Then use one hand on top of the other for firmer pressure, and it's more on the abdominal palpation. So we need to do this when you know that your patient is comfortable, you've already consented, gotten a consent from your patient, you have good rapport with your patient and good nurse-patient relationship or physician-patient relationship, then you can go ahead to do all this, and your patient will be able to actually trust you, and the information you're going to get through all the examinations will help you actually get the right a diagnosis and manage your patient very well. So nurses generally differs deep patient to examine the examiners. Sometimes nurses may decide to do a deep examination because the patient is saying, I feel like this side is paining, especially on the renal angles of the kidneys. And then instead of you going superficially, you start going deeper. So there the patient will not trust you. So you'll not be safe from this patient, and this patient will lose trust in you. So we are not supposed to generalize whatever we are doing, but we have to go systematically according to the techniques and according to the way the procedures are supposed to be performed. So when you're doing this deep palpation, you're going to try to assess whether the internal organs, the deeper organs, are either enlarged or not, whether they are masses or not. Then the one of superficial palpation is basically looking at the superficial abnormalities. So percussion, this one involves tapping fingers or hands against the body. Tito, have you ever done percussion?
Yes.
So can you explain briefly how you do it?
Percussion, what you do is you put one finger on the patient, let's say at the chest, on the chest, and then you try to use the other finger to tap on your finger. So you'll be able to know which sound you're hearing from the patient. Yeah. Yes. Hello. Hello.
No, so I was admitted myself, I didn't know. So I was saying,
Yes.
when you're percussing, you're supposed to put, especially when you're a right-handed person, you're going to use the list of the body that you're going to percuss. Then you use also your other middle finger from this right side to use for the other finger, the middle finger of the hand. And when you do that, you're able to hear the sound. So when you hear the sound, it depends on the area that you are percussing. And remember, different areas give us different sounds. So when you percuss the abdomen and you get a resonant sound, or the chest, then that one is normal. But when there is dull sound, then you can start suspecting an abnormality, either there is fluid, and you will go ahead to do other investigations to confirm, or there is enlargement of the organ, then you can go ahead to do either scan, ultrasound scan to confirm if there is any abnormality in the abdomen or around the organ that you're trying to percuss. Are we there?
Yes.
Hello?
Yes.
Okay, thank you. So percussion is used by the nurses, but mostly the doctors use it in the assessment. Nurses rarely use, but doctors frequently use it in the assessment. So no equipment. When you're percussing, you don't need any equipment. You only use your hands, your fingers, and that is all. And then also your knowledge, because you need to know the normal and the abnormal so that you can be able to differentiate whether what sound you're hearing is normal or it's abnormal to make you move to the next kind of plan. So no equipment is needed unless maybe you put on gloves if the patient has fluids around the area that you're going to examine or you're going to percuss. Then you can put on gloves to prevent contact to the body fluids of your patient. So direct percussion used to assess tenderness, so you can use it to assess either tenderness, So tap directly on the body part with 1 or 2 fingers. So you can use 1 or 2 fingers when you're percussing or tapping. So it's not that it's majorly one finger, but you can use it too, the index and the middle finger. Then you can use this other middle finger from your right hand side to tap and you listen to the sound. So ask the individual to identify painful areas and observe facial expressions. So before you start percussing, you can ask your client to tell you which part of the abdomen is paining or which part of your chest are you feeling pain. So when you're percussing, you start with the side that the patient is not feeling pain. Then when you come to the side where the patient is saying is feeling pain, you be very keen to look at the facial expression of your patient as you're percussing, and also very keen to listen to the sound that will come from that area so that you can be able to differentiate whether it is a normal sound or it is an abnormal sound. So indirect percussion generates sounds providing cues to underlying tissues. So this will now show you whether there is a problem. So you have to press the distal part of the middle finger on the body part, then flex the wrist. They're just trying to tell us how you are going to percuss. So your wrist should not be rigid, especially the one that you're going to use for tapping. It should not be rigid. Your wrist should be so flexible so that you can be able to tap very well to get to know the problem with the patient, or the sound should be clear, because your wrist has to be more flexible as you're tapping. You listen as you're tapping, you listen, and you'll be able to identify. So you listen to the sounds that are produced during tapping. Now on percussion. So percussion, production of sounds. So sound created by vibration producing characteristic waves. So there can be vibration, or there can be what? Characteristics waves that you'll be hearing either from the chest or from the abdomen that you're percussing. So what could be the components? There can be intensity, there can be frequency, or the pitch of the sound can be so frequent. The quality also have to look at it, and the duration. So when you're percussing, if there is any sound that you're hearing, what is the intensity of that sound? What is the frequency of that sound? What is the quality of that sound? And how long does it take? So when you percuss, as you listen, you have to be very keen. How long does it take for that sound to stop? And how strong is the sound as you percuss? So the words like light, flat, smooth, smoky, breathy, and rough describe sound quality. Then structures with more air, for example the lungs, they produce louder, deeper, and longer sounds. So the denser structures, for example the liver, is more dense when you percuss. So its sound is not so loud. So it produces softer kind of sound. And then sometimes in case there is a problem, then it can be more higher, and then also shorter sounds can be there depending on the kind of condition that the patient has in his liver. So examiner hears a note, hears and notes the base on underlying structure, body wall thickness, and technique used. So when you examine this patient, you have to know when you palpated, how were you feeling? Was it enlarged? So when you percussed, how was it? So the walls that we are percussing can sometimes also contribute to the sounds. So if the patient has very thick walls, especially patients who are very fat, sometimes they can also interfere with the sound during percussion. So you have to be very keen. Then also the technique that you're using also can interfere with the sound that is being produced. So you can mistake sometimes that this patient is having this problem, and yet maybe the technique you're using is not the right technique. So you have to put all that in consideration. Body wall thickness for patients who are very fat, then the patients who are thin. Also when you're percussing, you have to look at that, because the vibrations may come in a different way, then you'll mistake, and yet it's because of the thickness of the body walls. And then the duration is just the length of time the sound lingers or the sound takes. So when you percuss and there is a sound, how long does it take? Is it immediate and it ends, or it takes some time and then it stops? Then you have to describe the characteristics of the resonant sound. For example, the lungs can give that resonant sound, and then dull for the liver, for it gives that dull sound. So the resonant sound in the lungs is a normal sound. But when you percuss and you hear a dull sound from the lungs, then there is a problem. Then for the case of the liver, it has to give you a dull sound, and that one is normal. But if it gives you a resonant sound different from this, then you realize this liver has a problem. So each part of our bodies have different sounds. So when you see that this sound for the lungs is supposed to be resonant, but it is dull, then there might be either fluids in the lungs or there is consolidation of the lungs, and have to go ahead to investigate and find out what is happening in your patient's lungs. So basically, now we want to look at auscultation. And in auscultation, Tito, you mentioned about a stethoscope, and here in this slide, we are looking at the stethoscope. So when you go to examine your patient, it's very important for you also to know the different parts of the stethoscope. Sometimes we have the stethoscope, but we don't know the parts of the stethoscope, but we are using them. So this slide is trying to express to you the different parts of the stethoscope, and also how we use them, where we put them, and the reasons. So the ear tips are basically this. If I don't know whether you're seeing my cursor. Are you able to see my cursor, Tito? Are you seeing the cursor around?
Yeah,
Yeah.
yes, I'm
So
seeing.
yes, so these are the ear tips where you put to the ear to listen. Then these ones are the arrow kind of tubes, and these tubes basically are the ones that deliver the sound to the ear tips for you to hear. Then the headset, this one's the headset. These ones are also part of the connections of this tube, which also comes into the bell. This way where you see the diaphragm and then the bell this side. So these ones are just like the headsets, these two. Both of these are the headsets. Then when you look at this, is just the tubing that connects the sound from the bell, the drum, bringing it to the headsets, and then to the aerial tube, and you get the sound from the ear tips. So this is how the stethoscope looks like, and those are the different types, the different parts of the stethoscope. So when you're using them, you should know which part do I put in my ear, which part delivers the sound, where do I put the stethoscope to listen. Is it the diaphragm? Is it the bedside? So you should be knowing. So parts of the stethoscope, they have explained them in this slide. And the chest piece, this is the part you place on the patient's body. And the chest piece is divided into two sides. That is the diaphragm and the bell. So you should be knowing when you're listening to either the lungs, which side do you use. So the diaphragm is the one that you put to listen for the the heart murmurs and the lungs. Then for the case of the bell, that one you put, it gives you some low kind of pitchy sound, like sounds. So when they do surgery on the patient, you have to listen whether the patient has gotten back his bowel sounds before he starts to feed. So you use the side of the bell for listening. Then the tubing, I told you in the previous slide that it carries the sound waves from the chest piece to your ears. Then the earpieces are the ones you put to the both sides. Just like that. Then this one, the binaurals is that metal Y-shaped part which connects the tubing to the earpieces. So in auscultation, you have to use a stethoscope to listen to the sounds that are generated by various organs. So improving the client comfort and sound quality. So that is what this does in auscultation. So you have to introduce and verify identity, then ensure a quiet and private environment. Introducing yourself and verifying your identity is very important before you start doing anything. either to auscultate your patient, first have to introduce yourself. This is Tito, I'm a nurse in this hospital, or I'm a doctor, whatever, I don't know. Then when you finish that, then you tell the patient what you're going to do and how you're going to do it so that the patient doesn't get scared. So you have to ensure a quiet and private environment, perform hand hygiene because we may transmit infection from one patient to another. So we have to keep washing our hands before we go to one patient to the other. We wash our hands, then we move to the next patient. Then also clean the stethoscope with alcohol swab. So we disinfect our stethoscope after putting on one patient. Before you move to the next patient, disinfect it so that you don't cross-infect your patients. And then you warm it, the stethoscope, you warm it in your hands. You don't put it when it is cold. So you warm it so that you don't scare your patient with the cold stethoscope. Then expose the area for auscultation. You don't put it on top of the cloth or on top of the sheet. So you expose the area that you're going to auscultate. Then you put either the diaphragm or the bell and connect your earpiece and listen to the sounds. And close eyes for enhanced concentration. Sometimes when you keep opening your eye, you get interfered with whatever is happening and you don't concentrate to listen. So sometimes some people need to either close or look down and then see very well internally in their brain to try to understand what kind of sound they are hearing so that they can interpret it well. So stethoscope basically health examiners select stethoscopes based on individual needs. So it depends. Stethoscopes are very many. They have different sizes, they have different colors, and you can use them for different things, and you can use them to assess different organs or different areas. So it depends on what kind of stethoscope an individual wants. So there are many types. People prefer different types. So options include different tubing length, custom earpiece, and then the colors, which I've already mentioned. So you look at that and you say, this is the one I want, depending on your preference. And then usage of the stethoscope parts, it depends also what you want to use, where you want to use, in which part of the body. Then you can identify the type of stethoscope that you need, because you have the pediatric stethoscopes and you have the adult. So you can also decide, are you managing pediatrics, children, or you're managing adults? Then sometimes people prefer to have different sizes in relation to the ages of patients that they are handling. Then different patient positions for examination can also dictate the type or the size or the side of the stethoscope. Is it the diaphragm? Is it the bell that you need to use for listening? So the area that you need to listen will also dictate on the side that you want to use for listening, either the diaphragm or the bell side of the stethoscope. Then when you talk about auscultation, we use a stethoscope. Uh, then when you're using this stethoscope, they say auscultation guidelines have to be followed. So the different part positions for examination also have to dictate. So focus on identifying expected sounds first, then actual sounds. Then review techniques and indications for diaphragm and the bell use. So you should be knowing where should I apply the bell and which side should I apply the diaphragm. So for the case of the diaphragm, high-pitched sounds, you use the diaphragm on the high-pitched sound kind of organs. So that is the lungs, the bowels, and the normal hearts. So when you want to listen to the lungs or you want to listen, when you're doing this, you have to continue practicing. And when you continue practicing, to make you perfect on how you're going to handle your patients. So we need adequate light in physical examination, having mentioned about the importance of adequate light. So it will help you to assess and see the color of the skin of your patient. Then responding to dizziness. Some patients come and they are dizzy. So when they are dizzy, you have to handle them depending on how they are presenting to you. So you have to give them a chair, they sit, call for assistance, and then also ask what drugs they are taking, because it might be due to drugs. Then do vital signs, that is blood pressure, temperature, and so forth, for you to know what could be causing dizziness to your patient, and then also focus on the neurologic assessment to see why your patient is dizzy. Then lower extremity pulse, you also have to look at that, and then palpate the pulse. That may indicate arterial blood flow strength. Then in relation to extremity pulse, you have to look at the calm muscles does not provide information on arterial blood flow. So when you look at this, you are able to differentiate where the problem is and why is your patient either having maybe cold, clammy skinned, and then also why are the extremities maybe pale, what is causing all this and so forth. So the lower extremities, you have to assess either the pulse, and when you look at the pulse, it can tell you the blood flow at the lower extremities. If there is no enough blood flow on the lower extremities, even the color will change because of lack of saturation for the extremities. It can make the colors to be either blue, then it can show you that this patient is having low blood supply to the lower extremities. So the organs in the abdominal quadrants, you have to know there are different organs in different abdominal quadrants, and I want to encourage us to know the different quadrants of the abdomen so that we can know the location of the different organs. As we auscultate, we can be able to tell this side I've listened, and that is the liver on the right upper quadrant. I've tried to percuss this side, but it's either dull because I'm feeling there's a pancreas at the epigastric area. So it is very important for you to understand the different organs in the different quadrants of our abdomen. So when you're working on your patient, you shall be able to understand the variations from the normal and the abnormal in various organs. So actually that is the end of our session today. Teacher, I want to thank you very much for being active, and I want to encourage even those who have been there that let's always concentrate and be alert. I'm happy when I'm asked a question, and I'm happy when people interact with me. Other than that, I want to appreciate each one of you who has managed to be in. Thank you very much.